CME. Now I request Dr. SVL sir to introduce about our speaker, eminent speaker, Dr. Edwin Fernando Garu, and please proceed, sir.
Good evening, friends. It's very nice to see you all. After the new executive has taken up the position in last February, this is the first of the series of meetings. I wish the new executive will have a good beginning and have a great going on. On behalf of the APSN, I welcome Dr. Edwin Fernando, Professor and Head of the Department of Nephrology, Stanley Medical College, Chennai. To introduce him, I believe there is an adage in Telugu. Munjeti kankanamanku addamela.
What does it mean?
To see a bracelet, why do you require a mirror?
For eminent people, introduction doesn't require.
So I don't venture into introducing Edwin to our colleagues here, but brief to say, he is an eminent teacher, a passionate researcher, and above all, which made me a good friend of him, is a great human being. He has very many publications, delivered important lectures on very important podia so far, trained a generation of students who are into their practice across the world, not to say more. Coming to SGLT2 receptor inhibitors, really they have emerged as a miraculous molecule group in the last decade. Humanity knows this molecule for at least 150 to 160 years in its various forms known as florism, with all the complications. Last decade, intense research has shaped it one of the finest tools available in our armamentarium to treat and prevent variety of disabilities of human beings. We are not surprised even it is being mooted as an anti-aging molecule now. Okay. So today, Professor Edwin is going to speak about SGL2 receptors' role in glomerular disease in precision. Before I invite Dr. Edwin, I have a feeling to say that an apple a day keeps the doctor away as an old adage. Now, an apple bark molecule a day keeps many diseases away because these are the molecules that we have extracted from the apple tree bark. With this brief introduction about the great molecule and great human being, I invite the lecture to be taken away. Welcome, Edwin. Please do it.
Thank you, SVL. Nice to see you and a great friend. You've been very magnanimous in your introduction of me. Maybe I don't deserve everything, all what you said. I shall try to live up to some of the virtues that you mentioned. And thank you, Madhav, for the invitation. And good evening, friends. Slides visible?
Yes.
Right. So this is something that I read very recently. This is about the SGLT2 inhibitors in the treatment of glomerular diseases. We shall discuss the pros and cons of the molecule. So this is Stanley Medical College, Government Stanley Medical College, hospital that's 200 years old, and a medical college that's about 85 years old. During the famine in the Chennai Madras Presidency, those days, gruel used to be served here. And hence, it earns a name called Kanji Totti Hospital.
Mm-hmm.
So their gruel was served here. And this is the third floor of this block is where we function from. So this is what SVL also mentioned just now. SGLT2 inhibitor is now believed to be a blockbuster drug, just like how you have blockbuster movies. So this is the new take on an old adage. An apple a day keeps heart failure, kidney disease, and MIs away. And it's well known that SGLT2 inhibitors are derivatives of a fluorescein from the bark of an apple tree. Just to brush up the basics a little, these are the two types of transporters that are available. One is the SGLT1 and the SGLT2. The SGLT2 is found in the pars recta segment of the proximal tubule, S1, S2, S3, where 90% of the glucose reabsorption takes place. And there is a SGLT1 in a little distally, which reabsorbs about 10% of the filtered glucose. And this is what happens in the proximal tubular cell. The sodium and the glucose are in a 1:1 stoichiometric relationship. Both enter the cell from the luminal side. And this glucose is get reabsorbed into the bloodstream by the glut pathway. And the sodium and the potassium, the sodium participates in the sodium-potassium ATPase pump, which makes this pars recta segment a very metabolically active and energy-requiring segment. So what do these SGLT2 inhibitors do? Now, these SGLT2 pathway is here. So you are giving an SGLT2 inhibitor. So you're blocking this SGLT2, which means that the sodium and the glucose are getting excreted into the proximal, not getting reabsorbed. So they are getting excreted into the proximal tubule. As the more sodium reaches the macula densa through the tubular glomerular feedback is restored, it sends signals to the afferent arteriole to constrict. This reduces the intraglomerular pressure, which means that the intraglomerular pressure reduces, as a result of which the proteinuria reduces. So this is a mechanism that works with SGLT2 inhibitors. Of course, there's the efferent arteriole where the RAS system works, and this afferent arteriole where the SGLT2 inhibitor works. So the pleiotropic effects of these drugs are well known. Almost every specialty in medicine has started using these drugs. And as the indications for the drug keep on increasing, from our side, it definitely lowers the blood pressure. It causes body weight loss, slower loss of EGFR, lower HbA1c, the plasma volume can drop, less cardiovascular outcomes, anti-inflammatory qualities, and anti-fibrotic effects. So what does it translate into? It translates into lesser heart failure, lesser fat mass. There is definite renoprotection that has been proved in major studies. It reduces the steatosis and probably has a role in NFALD. And as SVL was mentioning, probably it will be used as an anti-aging agent. We are all aware of this Credence and the DAPA-CKD trials. Our team at Stanley was part of both these major international trials. And both these trials had to be terminated early because the efficacy of the drug was very clearly seen much earlier than the anticipated end of the trial. So the Credence, DAPA-CKD, and the EMPA-Kidney trial showed the good outcomes, renal outcomes, with the use of SGLT2 inhibitors. Now, what do these drugs mean in the treatment of glomerulonephritis? It's still unresolved. There are various limitations. There are some evidences that support the use of the drug. There are some limitations of their use, which are definitely of concern. I shall discuss the pros and cons and the conclusive balance on their role in clinical practice. I think we have to really wait for some time before we get clear conclusions. So I'll begin with this adage, the illusion of truth. Why we must not stop asking questions. All humans are actually susceptible to the illusion of truth effect, which means that more we hear something, the more we believe it's true. But we should go by evidences. It's better to debate a question without settling it than to settle a question without debating it. So this is Joseph Joubert, a French moralist and essayist, who mentioned this, and I shall take you through this debate. So these are the postulated mechanisms for the benefit of SGLT2 in patients with nephrotic range proteinuria, where there is an improvement in the mesangial expansion, this reduction in the reactive oxygen species and inflammation. So which means there's lesser interstitial fibrosis. The afferent arteriolar constriction, which I mentioned earlier, reduces the intraglomerular pressure and the intraglomerular hyperfiltration. Probably there is some effect of on the limitation of podocyte dysfunction and a protective effect on the glomerular endothelial cells. So all this could probably contribute to the reduction of albuminuria and improvement of kidney function. Now, we all know the afferent arteriolar vasoconstriction, the reduction in intraglomerular hypertension, the reduction in blood pressure. Probably there is a reduction in inflammation, which I mentioned, a beneficial effect on uric acid, and probably some beneficial effect on mesangial cell injury and glomerular endothelial injury. Whether this is related to the glomerular effect or some downstream events that happen in the tubules is again not very clear. Yes, again, this is another picture that shows the same thing all over again. How hyperfiltration and vasoconstriction of the afferent arteriole leads to lesser hyperfiltration. And also this, as I mentioned, the downstream events, the pro-inflammatory signaling could be taken care of, the NF nuclear factor kappa B signaling, ICAM1, MCP, profibrotic pathways. All this could be ameliorated by this drug. So this is the same thing which I put in another form: anti-hyperglycemic, anti-inflammatory, antioxidant, hemodynamic changes, decrease the glomerular and tubular injury, promote TGF, so decrease glomerular hyperfiltration, reduces body weight, improves lipid profile, natriuresis, and decrease serum uric acid. So let us look into the pros, the perspective of somebody who supports the role of SGLT2 in glomerular disease. So we know about these large-scale trials, DAPA-CKD in EPA kidney. SGLT reduces the risk of CKD progressions and cardiovascular disease in patients with CKD, including those with glomerular disease. So specific sub-analysis of these trials in patients with IgA nephropathy and FSGS have demonstrated benefits in terms of reduction of proteinuria and or eGFR decline. Observational studies have also shown that they reduce proteinuria, slow eGFR decline with various other glomerular disease, even those with persistent proteinuria despite other treatments. And the additional therapeutic benefits, reducing the risk of hyperkalemia, modestly lowering BP, and offering weight loss benefits have been well demonstrated. So this visual abstract from David Wheeler's study, this is a pre-specified analysis of the DAPA-CKD trial, and it shows the effect of IgA nephropathy compared to the placebo, and you can see the DAPA survival much better. So and if you look at this forest plot, it shows that in patients with IgA nephropathy, DAPA was definitely better compared to the placebo. So the conclusion from this study, this pre-specified analysis was, in patients with IgA nephropathy, when added to ACE inhibition ARBs, DAPA significantly and substantially reduced the risk of CKD progression. When major trials are done, when the ethics committee questions these trials, we cannot stop ACE inhibition or ARBs because these are definitely time-tested therapies for any glomerular disease. So DAPA is definitely an add-on to ACE inhibition or ARB. So in patients with IgA and FSGS, again, looking at compared to the placebo, you find that DAPA definitely had a lot of benefits in terms of primary endpoint, the renal endpoint, in the biopsy, and the patients who are at risk to develop CKD. This is the forest plot that I showed you earlier, and it definitely shows that DAPA is better than the placebo. What are the limitations of this study? Now, this is not a study specifically designed to test the hypotheses in patients with IgA. It was actually done in all CKD patients. So in this particular subgroup, the relatively small sample size, so it limits the precision of estimates of treatment effect on the study endpoints. So when the analysis presented herein was included in the original study design without knowing how many participants with IgA nephropathy would ultimately be enrolled. And only after recruitment, they found the largest number of patients with glomerular disease had a diagnosis of IgA nephropathy. Another major limitation is only about 16%, 16 patients, 6% had not undergone a kidney biopsy. A diagnosis of IgAN was based on clinical acumen of the investigator. And it is possible that some or all of them had another glomerular disease or kidney disease. So excluding the 16 patients did not alter the conclusions of the study. It did not assess mortality and cardiovascular endpoints in participants with IgA nephropathy. 3 patients died, 2 of cardiovascular disease. 1 patient was hospitalized for heart failure. Again, small number of events precluded our ability to assess the effect of DAPA on these endpoints. The eGFRs were actually not collected after discontinuation of the study drug, unable to determine whether the initial reduction in eGFR were reversible after discontinuation of DAPA. Although the findings in this particular subgroup are robust, it did not investigate the effects of DAPA in patients with normoalbuminuria or normal GFR. Hence, the applicability of the current data of DAPA-CKD in IgA to a broader population may be limited. As I told you, this is originally not designed to look into IgA because there are a lot of other factors in IgA nephropathy. So they just took patients from this study, those who had IgA, and then looked into the data. So it was not a very well-planned, pre-specified analysis as mentioned. Now let us come to FSGS. So in this DAPA-CKD trial, 104 patients had biopsy-confirmed FSGS. 45 were randomized to DAPA and 59 to placebo. So the mean age was around 54 and GFR was 41.1. The primary outcome occurred in 8.9 and 11.9 participants randomized to DAPA and placebo respectively. So the conclusion here was DAPA led to a larger acute reduction in eGFR compared to placebo. The mean rates of chronic eGFR decline with DAPA and placebo was 1.9 to 4 respectively. So it was better with the DAPA. Adverse events leading to study drug discontinuation was similar in both groups, and fewer SAEs, serious adverse events, were less with DAPA. So the conclusion was among DAPA-CKD participants with FSGS, DAPA reduced the rate of chronic decline of eGFR compared with placebo, although this difference was not statistically significant. So what are the limitations of this interpretation of DAPA data in FSGS patients? Again, this was not specifically designed to test our hypothesis. Small sample size of the subgroup. Again, the analysis presented was included in the original study without knowing how many participants would ultimately be enrolled. And as a secondary analysis, the participants were not randomized to treatment groups. So this results in imbalance in the characteristics between these two groups. And 10% of patients did not have a biopsy done. Again, as this study was not designed to study FSGS, we do not know what was the etiology of this FSGS. We know that FSGS is a very heterogeneous disease, and it did not ask clinicians to subclassify FSGS. And we really do not know what patients had primary, what patients had secondary. Finally, it did not investigate the DAPA in patients with FSGS who had normal or near normal kidney function, or those with the eGFR below 25. And participants were not required to stop the study drug based on any eGFR threshold. So these are some limitations of this DAPA CKD trial, which the original investigators themselves accept. Now coming to the EMPA kidney trial, we first had an EMPA-REG study, and then this is a large trial, 6,609 patients. This trial was not done in India, so we could not be part of the study. We were part of the other two trials. Because of some insurance problems, we could not participate. India was not chosen as a center. So among a wide range of patients with CKD who were at risk for progression, EMPA led to a lower risk of progression of CKD or death from a cardiovascular cause than placebo. Now, in the EMPA kidney trial, 25% of patients had other glomerular diseases. For example, 817 had IgA and IgA vasculitis. Total of 1,669 patients had other glomerular diseases. 195 with primary and secondary FSGS, 96 with membranous nephropathy, 27 with lupus nephritis, 17 with granulomatosis with polyangiitis, 14 microscopic polyangiitis, and 13 had MPGN. The mean and standard deviation of the eGFR in patient glomerular disease was 44 plus or minus 17. The median ACR was 700 milligrams. The primary composite outcome of kidney disease progression or cardiovascular death occurred in about 13% of patients in the EMPA group and 558 in the placebo group. The relative reductions in the chronic rate of eGFR decline was notable across different disease groups in patients with other causes of glomerular disease. And a proportional reduction in study average ACR compared with placebo was minus 24, minus 23, and minus 2 respectively in these three disease groups. So the results from the EMPA kidney trial say that treatment with EMPA associated with reduced risk of kidney disease progression, eGFR decline, exhibiting comparable relative effects regardless of the underlying primary kidney disease etiology. So these findings, along with those from another pre-specified analysis of the same trial, EMPA reduced the rate of eGFR decline even in patients with minimal albuminuria. This provides robust evidence of the protective effects of the drug in a broad spectrum of patients with CKD, including those with glomerular diseases. This is another major trial, the immunonephrology group of the European Renal Association, where 493 patients with biopsy-proven glomerular diseases with persistent residual proteinuria, more than 1 gram, despite targeted immunosuppression and background therapy of RAS were enrolled. 203 with IgA and IgA vasculitis, 90 with primary secondary FSGS, 89 with membranous nephropathy, and 32 with lupus nephritis. Now, the geometric mean percentage change of proteinuria was significant, and these changes were consistent across all various underlying diseases, suggesting a potential beneficial cross-sectional effect within this spectrum of conditions. All of them had proteinuric disease. Participants with serum albumin less than 3.5 were less likely to achieve more than a 30% reduction in proteinuria, indicating that those with active nephrotic syndrome or massive proteinuria, it was less likely that they would achieve a reduction in proteinuria. So it can be hypothesized that serum albumin may serve as a discriminating factor, distinguishing patients exhibiting residual proteinuria primarily due to hyperfiltration, which are likely to show improved antiproteinuric response to RAS blockade or SGLT, and those with more pronounced impairment of glomerular perm selectivity resulting from other pathogenic mechanisms. So this group of patients may exhibit a less robust antiproteinuric response to RAS blockade or SGLT2 inhibition. So patients with a higher BMI exhibited a more substantial percentage reduction in proteinuria, which again says that obesity is a well-recognized predictor of kidney disease progression. So it may be beneficial this way. So these findings strongly suggest that the pivotal role of hyperfiltration abrogation as a central mechanism for reducing proteinuria with these drugs. Finally, consistent with the results in clinical trials, patients who achieved more than 30% proteinuria after SGLT2 initiation had a slow eGFR decline over time. So SGLT2 inhibitors could be added to conventional antiproteinuric therapy regardless of the underlying etiology. Despite this significant reduction, 55% of patients still exhibited proteinuria more than 1 gram at the last follow-up. So this means that there is an unmet need for optimal antiproteinuric response in certain patient profiles, which prompts us to look for new synergistic therapeutic approaches. SGLT2 to abrogate hyperkalemia. As we know that most of our glomerular diseases, including diabetes and other glomerular diseases, we use RAS inhibition. So SGLT2 inhibitors may offer an opportunity to enhance potassium excretion, given their primary tubular site of actions. So there's a meta-analysis involving 6 trials with type 2 diabetes and higher cardiovascular risk of CKD. And SGLT2 inhibitors consistently reduce the risk of serious hyperkalemia, potassium more than 6, across a range of subgroups, including baseline kidney function and history of heart failure, use of RAS blockade, diuretics, and the mineralocorticoid receptor antagonists. What does it do to blood pressure? It reduces systolic and diastolic BP. Again, we know that reduction of blood pressure, control of blood pressure is a very important factor in the progression of CKD. There have been some use of these drugs in the animal models of lupus nephritis. So it is possible that there's some potential effect of SGLT2 in the complement system, although results have not been entirely consistent. There's some Chinese studies on this. So what are the renal beneficial effects of SGLT2 inhibitors in non-diabetic patients? They delay progression of CKD, the role in the management of IgA nephropathy, potential role in the management of FSGS, decrease blood pressure, decrease proteinuria, and improve renal-related survival. Now let us go to the other side and see what are the cons of using SGLT2 inhibitors. Make the lie big, make it simple, keep saying it, and eventually they will believe it. So said Adolf Hitler. So let us look into the other side of this story. Evidence for the use of SGLT2 inhibitors in glomerular disease is limited. Even in the DAPA-CKD trial, it has been shown that it is limited in IgA and the FSGS subgroup. Secondary analysis of glomerular disease in this trial showed very wide confidence intervals for some primary composite outcomes with no significant reduction in the risk of kidney failure, especially in the EMPA kidney trial, probably because they were underpowered. Why they were underpowered? The anticipated closure came much earlier than the expected date. Antiproteinuric effects of SGLT2 is mild compared to other nephroprotective agents. Significant proportion of patients showed no major effect. The safety of SGLT2 during active immunosuppression is still to be verified. Would you give them steroids and also give them SGLT2 inhibitor? Would you, if somebody's on a Ponticelli, would you put them on SGLT2 inhibitors? There are concerns about risk of infection and other adverse events. The applicability of DAPA-CKD and EMPA kidney results to patients with GN is suboptimal for several reasons. Patients with normal renal function were excluded. Number one, those with proteinuria in the nephrotic range were represented little. The same holds true for patients with Black or the African American race, and those on active immunosuppression, they were not included. While the two trials included many patients with IgA and FSGS, other types of GN were underrepresented. And the antiproteinuric effect of SGLT2 inhibitors is mild compared with other nephroprotective agents. This is a secondary analysis of the EMPA kidney trial. The benefit of primary composite outcome or any progression of kidney disease was of borderline significance. Risk of kidney failure was not even significant. As I said, these weak results can be explained by the fact that the trial was underpowered. They did not have the sufficient power and the numbers, and it was stopped prematurely. Again, this weakness is further highlighted when calculating the number needed to treat and the absolute risk reduction. These are some statistical terms. So only 28 for the primary composite endpoint, but with a very wide 95% confidence interval, 16 to 647. So this, when the confidence interval is wide, then the significance becomes very questionable. Data for glomerular disease are stronger than DAPA-CKD, probably because it enrolled a higher percentage of patients with more advanced and thus more progressive CKD. If you look at the individual cardiovascular events, the DAPA-CKD and the EMPA-KIDNEY trial, the lack of statistical power is even more evident when looking at individual cardiovascular events. Only 13 patients with EMPA-KIDNEY were hospitalized for heart failure or died from cardiovascular causes. This is because of the low burden of cardiovascular disease in this relatively young patient population, the majority of whom do not have diabetes, heart failure, or peripheral vascular disease at enrollment. Similar data was also found in the DAPA-CKD. Only 24 patients had a history of heart failure, and only 34 were hospitalized for heart failure or died of cardiovascular causes during follow-up. Now, let's look into the surrogate endpoints in these trials. We all know the slope of serum creatinine, 1 by serum creatinine, has been validated as a surrogate endpoint for clinical trials. Now, the chronic slope is the choice when there is an initial acute drop in eGFR, as with SGLT2 inhibitors. In this respect, both trials showed significant favorable effect in reducing the eGFR decline in patients with glomerulonephritis. Along with the slope of eGFR, the percentage reduction in proteinuria has also been validated as a surrogate endpoint. So 30% reduction considered the gold standard for efficacy, especially in patients with high baseline albuminuria, and this happens to be the case for the SGLT2 inhibitors. In an exploratory analysis, it was found albuminuria reduction was the most important measured determinant of the benefit observed in EMPA-KIDNEY trial, explaining 1/5 of the effect on the chronic slope. The antiproteinuric effect, again, the difference is compared with placebo small. In the EMPA-KIDNEY trial, the reduction was only about 15%. In DAPA-KIDNEY, it's about 13.6%. Again, the confidence intervals are very wide. Close to zero indicating that in a significant proportion of patients had no effect. Possibly the lower systolic BP during follow may have contributed to the antiproteinuric effect and not a direct effect of the drug. So we all know that the synergistic effect of the RAS blockade and SGLT2 inhibition. With SGLT2 inhibition, there's afferent constriction. With RAS blockade, there is efferent dilatation. And here there's a combination of both. So probably this normalization of intraglomerular pressure due to increased afferent and decreased efferent resistance could be a potential for additive intraglomerular pressure reduction, potential for long-term renal protection. Then this is again extrapolation of data from the placebo-controlled DAPA-CKD clinical trial, that if you initiate SGLT2 inhibitor at a higher eGFR, it delays kidney failure by a longer time than initiation at a lower eGFR. So this shows that you have to start the drug earlier for better effects. So start it at a higher eGFR. So this is very obviously seen in this graph. When it was started earlier, look at this, it's almost approximately 11 years before the eGFR dropped, compared to about 6 years in the placebo group. This is the DIAMOND trial. This DIAMOND trial is DAPA in non-diabetic patients with CKD. This is a randomized double-blind crossover trial. A 6-week treatment with DAPA did not affect proteinuria in patients with CKD without diabetes, but it did induce an acute and reversible decline in the measured GFR and a reduction in body weight. So this diamond actually did not shine. Are SGLT2 inhibitors more effective than other specific treatment for glomerulonephritis? This will definitely remain unanswered until sufficient data and adequately powered network and meta-analysis become available. SGLT2 inhibitors, now considered standard of care, will be included in all future trials as supportive therapy and RAS blockade. The antiproteinuric effect of SGLT2 inhibitors appear to be lower than that of the targeted release budesonide, the endothelin receptor blockers, complement inhibitors, and lymphocyte modulators. Concerns that RAS blockade may have been underused or not fully optimized in some of the SGLT2 trials. Nevertheless, even if SGLT2 inhibitors exert only a modest antiproteinuric effects in GN, they seem to be particularly safe in this population. Can we use SGLT2 inhibitors during active immunosuppression? TAPA-CKD and EMPA-KIDNey trials excluded patients with recent immunosuppression. Only small studies have been published combining SGLT2 immunosuppression. They showed a lower rate of UTI successfully treated with antibiotics, but a relatively higher rate of drug discontinuation due to other adverse events. At present, caution should be exercised in older patients, in particularly those with in the history of recurrent UTI. So these are the 7 steps to successful SGLT2 use. Step 1, co-prescribe SGLT2 inhibitor with ACE or ARB. Step 2 is to check eGFR and potassium. Potassium is really not required, eGFR. Vasculitis, lupus nephritis, ADPKD, active immunosuppression, these were excluded from major trials, but we have pre-specified analysis. Again, use in non-immunosuppressed individual. Diuretic dose will probably need to be adjusted because many patients with proteinuria may be on diuretics. And continue the SGLT2 inhibitors. And advice on sick day rules that all of us are aware of. So maybe we should follow this algorithm. Again, at this moment, we have evidence only for this. If there is a glomerular disease, the primary disease, prompt remission of treatment is expected. Institute immunosuppression. If there is remission, well and good. If there is no remission, we are going to probably consider SGLT2 inhibitor, RAS inhibition, blood pressure control, manage cardiovascular risk. If it is a secondary FSGS or some other disease, then again, we have to go back to this last step. If it is primary, no immunosuppression indicated, prompt remission not expected, adverse cardiometabolic phenotype, again, you have to go back to this regime. So let me conclude here by saying that the evidence on the benefits of SGLT2 inhibitors progressively decrease at higher eGFR with no data for improved kidney outcomes in patients with preserved kidney function and those with proteinuria and nephrotic range. Antiproteinuric effect of SGLT2 inhibitors is mild in many instances, possibly because the disease is often sustained by immunological factors that are not affected by SGLT2 inhibitors. Safety of SGLT2 inhibitors during active immunosuppression is still to be verified. Safety in primary glomerulonephritis, again, has to be looked into. And it may constitute a more than welcome addition to the management of such patients. Everything we hear is an opinion, not a fact. Everything we see is a perspective, not the truth. Thank you for the patient listening. I think I've left everybody confused more. You're muted, SVL.
Yes.
You're muted.
I'm unmuted.
Yeah.
Okay. You have cleverly ended your topic by quoting the Stoic Marcus Aurelius. You have occupied both sides of the court. You have vehemently argued pros and convincingly argued the anti-points also.
Right.
And take-home points also you gave in a sober way. Yet to wait.
Yes.
Only modest proteinuric diseases may respond,
Yes.
and no evidence of going safely with immunosuppressed patients. Really, still the hype to settle and signs to go up. And I'm happy that you, being a party to DAPA CKD, you could with more authority and authenticity speak about it. We are happy that you are here with us on this evening. And now the topic is open for discussion. Any of the members want to talk about this or add a point or share a comment? Please start.
Saivani has asked, in case of UTI, will you stop or continue SGLT2 inhibitors? Yes, it's very clear that that you have to stop, treat the UTI. However, there are studies to show that there is not increased incidence of UTI. You have evidence, you have arguments on both sides, but a practical thing will be to stop, treat the UTI, and whether to re-challenge this patient with SGLT2 inhibitor is, I think, an individual decision. Dr. Martins asks, what is your take on SGLT2 inhibitor and PLA2R membranous nephropathy with subnephrotic proteinuria? Again, as I mentioned, along with immunosuppression, are you going to use the drug? I mean, things are not very clear. If you're going to treat somebody PLAR positive membranous nephropathy with the Ponticelli or with the Retux, whether to use SGLT2 inhibitor, again, has to be a very guarded decision. These are times that you may have a lot of guidelines, KDIGO, KDOKI and all that, but ultimately it is your patient and you'll have to take a call on such individual. There is no hard and fast rule that it should be used. One has to temper enthusiasm with these patients. Probably if you have exhausted your modified Ponticelli and if you have exhausted your other avenues of treatment like Retux, then maybe we could use SGLT2 inhibitor in such group of patients. Because in any immunological proteinuric disease, there is an immunological arm and then there's a non-immunological arm. Now, the immunological arm is not going to be tackled by the SGLT2 inhibitor, right? So it is only that hyperfiltration injury that is probably the downstream events that will be tackled by the SGLT2 inhibitors. So a membranous nephropathy with a problem in the podocyte is not going to be acted upon by an SGLT2 inhibitor. So my understanding is the immunosuppression or whatever treatment you're going to give for the glomerular disease has to continue. Your attempts there to treat the patient has to be first, rather than to start SGLT2 inhibitor along with the immunosuppression. So primarily you're looking, if it is a lupus nephritis, if you're going to use urolupus or a NIH, I think that is the first therapy. And after that, if there is some fixed proteinuria that happens, probably an SGLT2 inhibitor would help at that point of time. There's one chat. Which is better, EMPA or kidney? Any head-on trial? No, we don't have any head-on trials. There are no head-on trials of that. Again, it depends on individual comfort zones, etc. I think DAPA is now relatively affordable to patients compared to EMPA. I'm not sure whether empagliflozin price has been reduced. DAPA is definitely cheap. As nephrologists, we are always concerned about how much our patients spends on treatment. All of us are very concerned about it. We put ourselves in patients' shoes to check on that. In that way, probably DAPA on economic terms may be better.
Probably nothing else.
Any other queries? What is your take, SVL? What do you feel?
Certainly, even urinary tract infection, it has been really a fear response from the clinicians rather than a reality. It has not been really a problem at all.
Right.
And dapagliflozin, with the availability of the generic formulations, already our patients are on multiple drugs, raising
Right.
the cost of the prescription.
Mm.
Generic dapa is really handy now. It is helping us.
Yes.
Till what GFR you are going comfortably?
Maybe EMPA up to 20, not below that.
Not below, sir. So,
There is one trial that is ongoing that is called renal life cycle trial, where they are even trying it out on patients on dialysis.
exactly, even
So
less than 15 ml.
If somebody drops the GFR and is been on SGLT2 inhibitor, and if there are no other contraindications to stop, contraindications not to give, so you could still continue.
Yes.
It may give the cardiovascular protection that most trials have shown. As long as there is no contraindication, I think it can be.
Absolutely. It is really well tolerated. Well tolerated. We have been comfortable with that.
Yeah.
Madhav, are there any questions?
No, sir.
Shall we call it a day?
Yes, sir.
Edwin, as
Yeah.
expected, you have done really wonderful job. As Madhav was telling, we'll be looking forward for your lecture once again on this.
Yeah, sure.
We discussed it. We are eager
Sure.
to see you again.
Sure.
Thank you for being with us despite being a busy practitioner and teacher.
No, not at all. Not at all. My pleasure. My pleasure to. I give importance for all these events. One is we read extra. Second is meet good friends all over the place.
We
and share our ideas.
Exactly. We love seeing you again, Edwin.
Sure, Iswil.
Thank you, Madhav.
Thank you, sir.
Thank you. Thank you, Madhav.
Thank you, all the friends.
Thank you, Siddharth, for the arrangements. Thank you. Good night. Good night.
Thank you.
Good night and happy Diwali to all.
Exactly. Same
Thank
to
you,
you.
sir.
Happy to. Madhava, bye.
Yes, sir.
Bye.
Thank you,
Bye.
sir.